All right, good morning, and thank you for the invitation. So the title of this talk is Traditional Non-Invasive Testing and Interpretation and Alternative Methods, whether they're useful or not. So most of the published data has demonstrated that patients with risk factors, at least 1/3 of them have peripheral arterial disease. So I have nothing to disclose. It's going the wrong way. So our role, knowing that these patients with risk factors, 1/3 of them have peripheral arterial disease, is to identify who are these patients. And for this, we have different modalities. The basic non-invasive testing, including ankle brachial index, rest and exercise, segmental pressures, post-volume recording, arterial duplex, and other modalities such as CTA and MRA. We're going to go through some of them. Now, I'd like to start this discussion with an algorithm that most of us probably use. If a patient comes to see us and the history and physical is suggestive of peripheral arterial disease, the next test that we most likely would do is an ankle brachial index. And if the ABI is less than 0.9, you likely have peripheral arterial disease. And the next step is to do an anatomical assessment, whether you use DSA, CT, or MR, to plan an intervention if he has criteria for intervening or not. However, if the ABI is greater than 0.9, but you're still suspicious that the patient has peripheral arterial disease, because normally over 0.9 and less than 0.4, you do not have peripheral arterial disease. But if you are still suspicious, you send them to the vascular lab. And if the patient has an ankle brachial index of greater than 1.4, then this suggests non-compressible vessels, and you should also send them to the vascular lab. So as you know, the ABI is nothing more than the ratio of the highest ankle systolic pressure, with isthmus pes or posterior tibialis, over the highest brachiosystolic pressure. All you need is a continuous wave Doppler and a blood pressure cuff. Pretty good sensitivity, but excellent specificity, so you rule in disease. Normal ABIs, as you all know, is 1 to 1.4. PAD is defined as anything less than 0.9. If you have critical limb ischemia, you likely have an ABI of less than 0.4. Non-compressible vessels, as I mentioned before, will be those with supernormal ABIs, that is 1.4 or more. So as you see here, this patient has ABI on the right of 1.36. It's nothing more than the highest ankle pressure with the highest brachial pressure. And on the right side is 1.41. Now, this suggests that there's non-compressible vessels. So I said this is a good test with good sensitivity and excellent specificity. But you ought to consider alternative diagnostic tools, such as a toe brachial index. And we all know that any value less than 0.7 suggests peripheral arterial disease. Now, we also do exercise ABI, especially in patients who have a normal ABI that doesn't correlate with their clinic. We place them on the Gardner-Skinner protocol, constant speed, constant grade, treadmill inclination at 12 degrees, a speed of 2 miles per hour for at least 5 minutes. And we all know that any decrease of greater than 30 millimeters of mercury in the ankle pressures, or a drop in the ABI by greater than 20%, suggests hemodynamically significant peripheral arterial disease. Now, in normal exercise ABI, virtually exclude peripheral arterial disease. What about segmental pressures and post-volume recording? This allows us to identify specific locations where we likely have hemodynamically significant stenosis. And for this, we place blood pressure cuffs at the thigh, calf, ankle, transmetatarsal region of the foot, and the digits. Again, we use a continuous wave Doppler in the DP and PT region and obtain segmental pressures following the order that we have in this slide: ankle pressure followed by calf pressure, low thigh pressures, high thigh pressures, and obviously obtain bilateral arm pressures as well. So In segmental pressures, it's very important to realize that thigh pressure should be at least 30 millimeters of mercury higher than the reference arm pressures. And this is secondary to retrograde wave reflections in the resistant vessels that is additive to the antegrade wave. And any pressure gradient greater than 20 millimeters of mercury between adjacent levels suggests a hemodynamically significant stenosis. And the limitations of segmental pressures are the same as ABIs. Calcified arteries will not be compressible, so it will not be reliable, cannot determine stenosis versus occlusion. Segmental lesions are difficult to distinguish, and severe inflow disease makes infrainguinal lesions difficult to identify. What about post-folding recording? This is nothing more than plethysmography. It's a qualitative assessment. Normal PVRs are very similar to intra-arterial pressure waveforms, rapid upstrokes, rapid downstroke, dicrotic notch, and narrow complex with progressive disease. We have decrease in the amplitude of the waveforms, loss of the dicrotic notch, and then the waves widen. And as you see in the top left, you have a normal PVR, and the bottom right, you have an abnormal PVR. This is what a normal PVR will look like, which I'm sure you've seen on a daily basis, likely. So let's start with a couple of clinical cases. This is a 59-year-old patient, 4 years of right buttocks aching, only with walking, relief with stopping and standing, no rest pain, ulcer gangrene, that is no CLI, 50-pack year, history of tobacco usage, hypertension, hypercholesterolemia, palpable pulses in the right femoral popliteal, DP, and PT. And this is the ABI with segmental pressures. Notice that the right thigh pressure is not elevated to at least 30 millimeters of mercury above brachial pressures as we had defined in the past. So this suggests abnormality, and you really don't see a significant gradient between other adjacent levels. We have here color Doppler, a normal Doppler in the top of the screen, and an abnormal Doppler in this patient in the bottom of the screen with lower velocities and spectral broadening. Continuous wave Doppler is nothing more than low frequencies overimposed in brightness mode. So it measures red blood cell velocities. In the bottom, you see lower velocities, again with spectral broadening, suggesting a significant lesion. And as you would expect, in the angiogram, we see a severe common right iliac stenosis. So we must pay attention to the technique when we do our Doppler. We want to have 60 degrees as best as we can. Pay attention to the waveforms, not just the velocities. We want to consider all the information at our disposal and make sure you have a good vascular tech helping you out. Doppler waveforms, normally triphasic, but they also come biphasic and monophasic, especially in patients with severe disease. An increase in velocities obviously suggests a significant blockage or stenosis, and low velocities with spectral broadening is frequently seen in post-stenotic lesions. And we can also ascertain the degree of stenosis. For that, we use stenotic to pre-stenotic peak systolic velocity ratio. Any ratio less than 2 to 1 with triphasic waveforms suggests anything less than 50% stenosis. A 2 to 1 ratio with monophasic or biphasic waveforms suggests a 50 to 74% stenosis. A 4 to 1 ratio with monophasic waveforms and velocities are greater than 400 centimeters per second suggests a greater than 75% stenosis. And there's different algorithms and protocols that you may use. And obviously, if you have a preocclusive thumb, then that suggests that there is a 100% occlusion. So what about this patient? 80-year-old male, bilateral calf pain. You see this, that the ABIs are abnormal. The thigh pressures are not augmented to the level that we would expect for the reasons I mentioned in the past. And there is significant pressure gradient among several levels. You see here Dopplers, we're in the right common femoral. Velocities are a little low with a small amount of spectral broadening. However, when we move down into the SFA, you see there's interrupted color flow in the proximal region of the SFA. You see now metal within the vessel suggestive of a stent with low flow. Then you go to the right perineal and you see very low velocities with a tremendous amount of spectral broadening. On the left side, you see normal Doppler waveform with good velocities. However, when you start going down into the left proximal SFA, you see a significant drop in the velocity tracings and some spectral broadening. We go to the distal SFA and there's really no flow. And when we go to the proximal PTA, we see also hardly no flow whatsoever. Diagnosis is, as you would expect, bilateral iliac disease with a right SFA and popliteal occlusions, and left SFA popliteal and infrapopliteal occlusions as well. What about this case? A 76-year-old, status post right SFA stent, severe right lower extremity claudication after walking 1 block. But we look at the ABI is essentially normal, so the clinic does not correlate with the ABI. The most likely test that we would be doing is then a exercise ABI, and if you have a greater than 30 millimeters of mercury drop in the ankle pressures, that suggests a hemodynamically significant lesion somewhere in that extremity, and this is what happened with this patient in the right leg. You see a tremendous drop in the ankle pressures. This is the Doppler of the right common femoral. Velocities are okay, a little spectral broadening, not too much. We see good flow through the mid SFA. However, when you get to the distal portion of the mid SFA, you have a stent with some flow. Now you have low velocities with spectral broadening. And then towards the end of the stent, there's a much less decrease in flow. We see right around that area increased velocities at the level of the highest level of obstruction, suggesting a hemodynamically significant stenosis. So as you would expect, this patient has right SFA ISR. Now, is this enough? Well, not necessarily, because if you now identify that you have peripheral arterial disease, the next step is to determine what are we going to do with the patient. The patient is a claudicant and has lifestyle-limiting claudications, and you place them on an exercise protocol, started them on cilostazol, and the patient does not improve, then this is a patient that will likely be a candidate for some sort of intervention, whether surgical or percutaneous, or if it's a patient that presents with a critical limb ischemia, then these are the patients that you want to intervene earlier rather than later. And in order to plan these interventions, it is reasonable to use DSA. DSA has been the historical gold standard, but the accuracy of other modalities such as CTA and MRI are just as good. As you see here, we're comparing on the left side DSA, on the right side you see MRA. They're almost as precise in identifying significant disease. And you see here excellent accuracy in determining areas of occlusion. Limitations of MRA are the ones that we all know. Metal, especially in patients who have very old pacemakers and ICDs, the new ones are compatible, but you never know what your patient has. Obviously, calcification is always a problem, and patients who are uncooperative will have claustrophobia when you put them on the MRI tunnel. CT is as good. The issues issues with CT is that even though it has great accuracy, it's comparable with DSA as well as MRA, is the use of iodine contrast in patients who have renal insufficiency. It's probably not the best imaging modality that you can use. Limitations, as I said, the renal failure, because you use x-rays, then pregnancy, and it's not perhaps the best imaging modality for evaluation of pedal vessels. Thank you.